examination.
And we look at external rotation, and internal rotation is slightly limited. Not bad, and he's got full extension at the knee. And then we can get his ankle. This is actually probably a pretty good shot of the skin areas on the lateral foot, which means that foot is, as he's walking, he inverts and he gets pressure on the outside of his foot here.
Following the treatment algorithm, the development of a spasticity management program begins with patient evaluation and whether spasticity interferes significantly with function or may lead to musculoskeletal deformity.
Evaluation tools and techniques include the modified Ashworth scale, pain scores, spasm frequency, adductor tone, range of motion, joint resting angles, strength, motor control, fine motor coordination and ambulatory level, stair climbing skills, endurance, positioning, orthoses, and sleeping patterns.
Decreased spasticity in one area can precipitate functional changes in other associated or unanticipated areas. Therefore, evaluation must include areas beyond those being injected. The scales and techniques selected can be adapted to either the occupational or physical therapies, as well as the clinical setting.
Physical and occupational therapists are essential members of the treatment team in assisting in patient selection, assessing baseline status, participating in goal determination, providing therapy, and assessing outcomes.
I have just assessed Yia Tao, who's a little girl who has right-sided involvement or right hemiplegia, has a lot of tightness at her hip and her knee and at her foot. One of the things that's mostly impaired from that is her foot has such a deformity that she's not able to stand and do transfers on that foot or do weight bearing. So she's very limited in her ways of getting around. Plus she's 16 years old and she needs to be lifted for all of her transfers. She seems very motivated to do some more movement to help with transfers, probably come to stand out of them, and actually probably do more of an aggressive standing program. But right now her tone and her contractures from that are limiting that. My concern as a therapist is that it's really interfering with her function because it limits the transitions she can do and the activities she can do. Therefore, my recommendation would be that we would try conservatively, we would try to stretch out her foot position, probably by doing some Botox to her gastrocs and her posterior tibialis, and then if possible to serially cast her and get that foot down flat.
There are many factors that influence whether the outcome is beneficial as a result of spasticity treatment. Chronicity, severity, distribution, locus of injury, comorbidities, availability of care, and treatment goals are important in decision making.
There are many difficulties in treating Yia. The fact that she has not received adequate therapy in the first 15 years of her life makes her treatment exceedingly difficult. Yia also does not speak English as her first language. That language barrier can interfere with her therapy as a therapist try to instruct her in the proper ways to use her legs for ambulation, as well as other techniques to improve her overall mobility.
The appropriateness of any spasticity treatment depends on its ability to meet the goals of patient and caregiver, whether for improved function, comfort, care, cosmesis, or reductions of complications from spasticity. The clinical team works together with the patient and caregiver to clarify these goals, develop an overall spasticity management plan, and determine the role of chemodenervation treatment within this plan.
In the spasticity management program, range of motion exercises are indicated for almost all patients to prevent contracture. Oral medications, surgery, and intrathecal baclofen may also be useful in the properly chosen patient.
For Derek, treating his spasticity in his distal lower extremities, there are various different treatment options. One of them would be bracing alone. Given the amount of spasticity that he has dynamically and the amount of contracture that he has, bracing alone is unlikely to solve his toe walking problem. He would be a candidate for surgery to lengthen out those tendons However, given his age and some of the other complications that Derek has with his medical status, it would be prudent to try something more conservative, such as botulinum toxin injections.
Obviously, one of the most important factors in managing the spasticity is to pull together all the available tools and pick and choose which ones are best for your specific patient. And we found that it's particularly useful to manage difficult spasticity utilizing several interventions. So, for example, if you have a patient with a spastic hemiparesis who has very large, powerful muscles with a high degree of spasticity, we get a good response by using phenol blockade for proximal large muscles such as the biceps or the thigh adductors, and then using botulinum toxin injections for the smaller distal muscles. At the same time, we may also combine these injection chemodenervation techniques with oral spasticity, anti-spasticity agents, and physiotherapy or bracing. So the combination of strategies has been very rewarding.
If spasticity is focal and a controlled reduction of muscle overactivity would be helpful in reaching treatment goals, consider chemodenervation with phenol or botulinum toxin type A for overactive muscles.
The role of phenol in the management of spasticity is very specific. If there is one group of muscles that is producing marked overactivity, such as the biceps or adductors, then you can achieve a very nice reduction in that muscle overactivity with a blockade of the motor nerve using the phenol injection technique. The key to the most successful use of phenol in management of spasticity is patient selection. Clearly, it's important to make sure that the patient and the physician have come to some agreement on their treatment goals, and that technically this is something that is achievable. So, for example, if you have a patient who has generalized spastic quadriparesis and the patient hopes to walk again, that treatment objective may not be possible simply with a phenol block. On the other hand, if you have a patient who has a focal area of profound spasticity, such as elbow flexion or thigh adduction, then a phenol block may be very successful in achieving that treatment goal.
Like phenol, botulinum toxin type A is most appropriate as a treatment for focal spasticity interfering with some aspect of function, comfort, or care. It may be used in both proximal and distal muscles, although the potential for antibody development at higher doses may limit its utility in the more powerful muscle groups. As with phenol, appropriate patient selection is critical to the successful use of botulinum toxin. The clinical team must work with the patient and caregiver to help them understand both the benefits and limitations of therapy. Phenol chemodenervation has been used to treat spasticity since the mid-1960s. Botulinum toxin type A has been in clinical use since the 1980s, and its use for spasticity has increased dramatically in recent